Acne resistant to standard topical treatments, particularly if inflammatory and deep, often reflects hormonal causes. Women with other hormonal symptoms, irregular periods, excessive hair growth, hair loss, fertility issues, should definitely pursue hormonal evaluation. Primary hormone involved in acne is androgen, particularly testosterone and DHT, dihydrotestosterone. However, most women with hormonal acne have normal total testosterone levels but exhibit heightened skin sensitivity to androgens. This explains why some women with normal hormones still have significant hormonal acne. It's about skin sensitivity, not absolute hormone levels. Relevant hormonal tests for acne evaluation include total testosterone, free testosterone, calculated or direct measurement, DHT, dihydrotestosterone, DHEAS, dehydroepiandrosterone sulfate, LH, luteinizing hormone, FSH, follicle-stimulating hormone, and androstenedione. These tests assess androgen status and ovulatory function. Additionally, tests for other hormones affecting acne include estradiol, progesterone, tested in luteal phase for ovulation confirmation, cortisol, for stress-related endocrine effects, and thyroid function, TSH, free T4, may be relevant. Ovulatory dysfunction, present in conditions like PCOS, contributes to hormonal acne. PCOS involves elevated androgen production, irregular ovulation, and insulin resistance. Women with PCOS typically have irregular periods, acne, hirsutism, excessive hair growth, androgenetic alopecia, pattern hair loss, and often obesity. Testing for PCOS is appropriate for women with these symptoms. PCOS diagnosis requires ovulatory dysfunction, irregular periods, plus hyperandrogenism, elevated androgens or clinical signs, and/or polycystic ovarian appearance on ultrasound. Baseline hormonal testing during the follicular phase, first 7 days of menstrual cycle, is standard because hormone levels are more stable and baseline during this phase. FSH and LH are assessed during the follicular phase. Progesterone is tested during the luteal phase, typically 7 to 8 days after ovulation, to confirm ovulation occurred. Testing hormone levels at the wrong cycle phase produces misleading results. Understanding test results requires expert interpretation because normal ranges vary widely and what's normal for general population might indicate androgen excess relative to individual baseline. A testosterone of 50 ing/dL is normal for most women but might represent significant elevation for a particular individual. Free testosterone is often more clinically relevant than total testosterone because it represents the active hormone, though measuring free testosterone is technically challenging and prone to error. Elevated DHEAS, particularly if greater than 350 μg/dL, suggests adrenal androgen excess and warrants further adrenal evaluation. Elevated androstenedione suggests adrenal or ovarian androgen production. Elevated LH with normal or low FSH suggests ovulatory dysfunction characteristic of PCOS. If hormonal testing reveals significant androgen excess, additional testing might assess the source. Adrenal tumors or ovarian tumors very rarely cause acne but can cause very severe hyperandrogenism. Evaluating clinical presentation helps distinguish adrenal from ovarian sources. ACTH stimulation testing can differentiate adrenal from ovarian androgen excess if warranted. Interpreting results in clinical context is essential. You might have borderline elevated testosterone with classic hormonal acne, jawline breakouts, cyclical pattern, making hormonal treatment appropriate despite normal lab values. Conversely, you might have elevated testosterone labs without significant acne, making hormonal treatment unnecessary. Clinical presentation guides treatment more than isolated lab values. When to pursue hormonal evaluation: irregular or absent menstrual periods, acne with cyclical menstrual pattern, acne onset in adulthood, acne concentrated on jawline and lower face, acne resistant to standard treatments, signs of hyperandrogenism, hirsutism, hair loss, male pattern baldness, family history of PCOS or hormonal disorders, concerns about fertility. Other reasons to evaluate hormonal status. Additionally, pursuing evaluation before starting hormonal treatments gives baseline data to assess treatment effectiveness. Working with appropriate clinicians, gynecologists are ideal for hormonal evaluation in women, though some dermatologists also perform this evaluation. Reproductive endocrinologists specialize in hormonal disorders and are appropriate referrals for complex cases or PCOS evaluation. Family medicine physicians can perform initial evaluation. Choosing a clinician experienced in hormonal acne and PCOS improves evaluation quality. After hormonal evaluation, appropriate treatment depends on findings. If PCOS is confirmed, treatment includes hormonal contraceptives for acne and period regulation, spironolactone, antiandrogen, metformin for insulin resistance, and lifestyle modification. If adrenal androgen excess is identified, dexamethasone might be considered. If results are normal despite hormonal acne pattern, empirical hormonal treatment, oral contraceptive or spironolactone, remains appropriate despite normal labs. Timeline for hormonal treatment effectiveness is months, not weeks. Hormonal treatments typically require 3 to 6 months to show acne improvement, with maximal improvement often occurring after 6 to 12 months. Patience is necessary. Discontinuing hormonal treatment after 2 to 3 months before full benefits appear is a common mistake. Reassessment after hormonal treatment initiation is valuable. Repeating key hormonal tests, particularly free and total testosterone, after several months on hormonal treatment confirms that the treatment is achieving hormonal effects. If testosterone hasn't decreased despite hormonal treatment, investigating why: medication noncompliance, inadequate dosing, ineffective treatment choice, is appropriate. Guide 38, Dietary Supplements for Acne, Evidence-Based Review of Oral Supplements. Numerous dietary supplements are marketed for acne with varying levels of evidence. Understanding which supplements have evidence, realistic expectations for supplementation, and appropriate dosing guides inform decisions about supplementation. Zinc supplementation has evidence for acne improvement, particularly in individuals with zinc deficiency. Zinc supports immune function, wound healing, and inflammation reduction, all relevant to acne. Studies show that oral zinc at 30 to 50 mg daily improves acne moderately. However, excessive zinc supplementation, above 150 mg daily long-term, causes nausea and interferes with copper absorption. Typical zinc supplementation is 25 to 30 mg daily. Zinc is more effective for those with demonstrated zinc deficiency, though some people without deficiency also benefit. Blood zinc levels can be tested to assess zinc status, though zinc testing is not widely available. Vitamin D supplementation shows promise for acne. Vitamin D has immune and anti-inflammatory effects relevant to acne. Low vitamin D levels correlate with worse acne. Vitamin D supplementation at 1000 to 400 IU daily might improve acne, particularly in those with low baseline levels. However, evidence is mixed, and benefits are modest. Vitamin D supplementation is generally safe and supports overall health beyond acne, making it reasonable to consider. B vitamins, particularly B5, pantothenic acid, are promoted for acne. Pantothenic acid is marketed at very high doses, 10 grams daily, claimed to reduce sebum production. While some small studies suggest benefit, evidence is weak. High-dose pantothenic acid causes diarrhea frequently and benefits aren't reliably demonstrated. Supplementation is not recommended without stronger evidence. Omega-3 fatty acids, fish oil supplementation, support anti-inflammatory effects and improve acne in some individuals. Omega-3s reduce systemic inflammation and support skin health. Typical supplementation is 1 to 2 grams daily of combined EPA and DHA. Fish oil same evening will cause severe irritation. Once your skin is adapted to retinoids alone, typically after 8 to 12 weeks, you might carefully introduce another active on different evenings. Eventually, some people successfully combine retinoids with other treatments, but build up to this gradually. Vitamin C and other antioxidants can be used with retinoids. Apply vitamin C in the morning and retinoids at night, or apply them on different days. Niacinamide can be used with retinoids in most cases, but some people find them together irritating initially. SPF 30+ broad-spectrum sunscreen is absolutely mandatory every single day when using retinoids, even if you don't plan to go outside. Window glass blocks most UVB rays but not UVA rays, meaning significant sun damage can occur even indoors. Reapply sunscreen every 2 hours if you'll be in the sun. Wear protective clothing, hats, and sunglasses when possible. The combination of retinoid use and sun exposure can cause severe reactions and permanent skin damage. As your skin adapts to retinoids over 8 to 12 weeks, gradually increase usage frequency. After tolerating 2 to 3 times weekly for 4 weeks, increase to 3 to 4 times weekly. After another 4 weeks, increase to 5 to 6 times weekly. Eventually, many people use retinoids nightly. This gradual progression minimizes irritation and maximizes adaptation. If you experience severe irritation, excessive peeling, or significant discomfort at any point, reduce back to a lower frequency. There's no rush. Building retinoid tolerance over several months is perfectly acceptable. Consistency matters far more than speed. Someone using retinol 2 to 3 times weekly for years will see better results than someone who uses it daily for 2 months then stops. Results from retinoid use appear gradually but are remarkable. After 4 weeks, you might notice smoother texture and reduced comedones. After 8 weeks, reduced acne and early signs of improved skin tone. After 12 weeks, significant acne improvement, smoother texture, and visibly improved skin. After 6 months, improved fine lines, more even skin tone, and dramatically clearer skin. After 1 to 2 years, comprehensive skin improvement including acne prevention, minimal fine lines, even skin tone, and visibly healthier, more resilient skin. Prescription retinoids like tretinoin work faster than over-the-counter retinol. Starting tretinoin at 0.025% and increasing gradually can show acne improvement within 6 to 8 weeks rather than 12 weeks. However, prescription retinoids cause more significant initial irritation, making the starting process more challenging. Many dermatologists recommend beginning with over-the-counter retinol to build tolerance, then switching to prescription retinoids if additional strength is needed. Retinoids are teratogenic, meaning they can cause birth defects if used during pregnancy. Women of childbearing age should use reliable contraception when using retinoids and should discontinue use if planning pregnancy or if pregnancy is suspected. Men can use retinoids without this concern. Common mistakes with retinoids include starting with too high a concentration, using them too frequently initially, applying to damp skin, using them with too many other actives, or discontinuing them during the retinization phase. Starting right requires patience and conservative progression. The reward for proper retinoid use is clear, youthful, healthy skin that continues improving even after years of use. Guide 7. Hormonal acne in women, causes, recognition, and comprehensive medical management. Hormonal acne is a distinct type of acne that affects many women and some men, following predictable patterns related to hormonal fluctuations. Understanding hormonal acne's unique characteristics and treatment approaches is essential for women struggling with acne that doesn't respond adequately to standard topical treatments. Hormonal acne typically appears as deep, cystic lesions, often concentrated around the jawline, chin, and lower face. These lesions are painful, tender to the touch, and located deep within the skin rather than on the surface. They're often described as having no head, meaning they don't develop the white or yellow center that surface pimples have. They can persist for weeks or even months without fully resolving. Unlike typical acne that might be spread across the face, hormonal acne often appears in the same locations repeatedly. The hormonal pattern of acne is highly telling. Many women notice breakouts occur in a predictable pattern related to their menstrual cycle. Breakouts might appear 3 to 5 days before menstruation begins, resolve during menstruation, then reappear in the luteal phase, after ovulation. This cyclical pattern is a clear indicator of hormonal involvement. Some women break out only during specific phases of their cycle, while others experience breakouts throughout the cycle with worsening at predictable times. Hormonal acne results from heightened skin sensitivity to androgens, particularly testosterone and DHT, dihydrotestosterone. These male hormones stimulate sebaceous glands to produce more sebum, even in the presence of normal hormone levels. Additionally, androgens promote follicular hyperkeratinization and may increase colonization of acne-causing bacteria. Women's testosterone levels fluctuate with their menstrual cycle, with higher levels during the luteal phase, explaining the predictable timing of hormonal acne breakouts. Recognizing hormonal acne requires tracking your breakouts. Keep a calendar marking breakout dates and your menstrual cycle dates for 2 to 3 months. If breakouts cluster around specific menstrual cycle phases, hormonal acne is likely. Polycystic ovary syndrome, PCOS, a condition affecting ovulation and hormone regulation, often causes severe hormonal acne. Women with PCOS typically have elevated androgen levels and irregular menstrual cycles. Topical acne treatments alone are often insufficient for hormonal acne. While they help manage symptoms, they don't address the underlying hormonal cause. Therefore, treating hormonal acne often requires systemic, oral, medications that regulate hormones or reduce skin sensitivity to hormones. Hormonal contraceptives are the first-line treatment for hormonal acne in women who desire birth control. The hormones in birth control pills suppress ovulation and, importantly for acne, reduce circulating androgen levels. Specifically, oral contraceptives increase sex hormone-binding globulin, SHBG, a protein that binds androgens and makes them unavailable to skin cells. The result is reduced sebum production and decreased follicular keratinization. Not all birth control pills are equally effective for acne. Combination pills containing estrogen and progestin are effective. However, some progestins have androgenic properties, meaning they act similarly to testosterone, and can worsen acne. Progestins with lower or no androgenic activity include norgestimate, desogestrel, and drospirenone. Birth control pills specifically approved for acne treatment by the FDA include orthotricycline, norgestimate, estrostep, norethindrone, 𝑺𝒐𝒐𝒕𝒉𝒊𝒂𝒂𝒍, drospirenone, and 𝑵𝒂𝒔𝒔, drospirenone with additional vitamins. These pills typically show acne improvement after 3 to 4 months of use, with maximum improvement by 6 months. Starting a new birth control pill doesn't immediately improve acne. Acne often temporarily worsens in the first 1 to 2 months as your body adjusts to new hormone levels. This temporary worsening isn't a sign the pill won't work, it's normal. Stick with your chosen pill for at least 3 months before concluding it isn't working. If after 3 months acne hasn't improved, discuss switching to a different progestin or a different pill formulation with your gynecologist or dermatologist. Spironolactone is an alternative or complementary treatment for hormonal acne. This medication is a potassium-sparing diuretic that also acts as an androgen receptor antagonist, blocking androgens from affecting skin cells. Spironolactone is typically used at doses of 50 to 100 mg daily for acne treatment. It's often prescribed in combination with birth control pills for additional effectiveness. Spironolactone requires careful monitoring. Potential side effects include dizziness, lightheadedness, menstrual irregularities, and breast tenderness. More serious but rare.
Thuốc, chị cho thuốc về uống. Với lại những cái đèn qua đây xíu.
Thuốc mấy một ngày mấy một tuần, thuốc mấy một đây bộ.
Ngày 4 tháng 8.
4 tháng 8 rồi. 1 2 3 4.
Mấy dụng cụ
5 tuần luôn đó. Là bữa nay là 17 đó.
Mấy dụng cụ mà chị làm là dùng riêng hết cho từng khách nha.
Dạ.
Dùng một lần mình bỏ nên em yên tâm nha. Trời quá trời luôn nè. Chịu được không em?
Dạ được.
Chịu được. Cố gắng một xíu cho hết mụn ha. Chứ không cái mặt em nó rỗ hết. Hai chị em là ở quận mấy hả em?
Em ở Thủ Đức á chị.
Thủ Đức à?
Dạ.
Ừ.
Chị em quay được không?
Được. Để lát chị gửi cho.
À dạ ok chị.
Lát chị gửi qua cho.
Cái này mà không lấy lấy xúc kiểu gì đâu không hết nổi.
Đúng rồi, nó nhiều quá rồi nè, dày luôn á. Mấy cái sản phẩm bôi nó chỉ hỗ trợ thôi chứ nó không tiêu được cục mụn này đâu em ạ. Ví dụ như nó hỗ trợ gom nhân mụn này, nó hỗ trợ để làm mềm da nè, nó hỗ trợ để nhanh lành thôi. Chứ còn bôi cục mụn bự cứng vậy sao mà nó ấy được.
Bây giờ sau này là phải giữ da cho sạch đúng không chị?
Ừ. Tại cậu này hay hoạt động ngoài trời.
Đúng rồi.
Với mùa hè này nè, mùa hè thì mồ hôi. Mới có một xíu da chỗ này thôi mà nhiêu đây rồi.
Mẹ nói là cũng không có hay cậy hay đồ á chị.
Ừ. Có sao để nguyên vậy đúng không?
Nó cũng sợ chứ không, chứ nghĩ là nó khó chịu lắm.
Để lâu nó bị viêm lên nè, mấy nốt này là viêm rồi nè. Nhìn cục mụn bự không à. Cố gắng lên nha.
Không sao.
Cố gắng lên. Lên chậm màu hết. Này mà đi trễ cái nữa, thời gian nữa là nó bị viêm hết mặt luôn á. Rồi sau đây. Con nhiều mụn lắm bên này, mình cố gắng chút nha. Nhiều mụn lắm nè, dài hết hai bên má rồi. Linh mụn nhiều quá trời đây chị.
Tại nó kẹt thi á.
Dạ.
Không có loại được.
Quá trời luôn. Dán lên xíu con. Con nhìn sát vào đây.
Con có dán số con không? Nhưng mà chị nhớ lúc trước chị đăng anh số chị với anh số bé rồi bán tải 3 số cuối của con là gì sao? Gì chỉ có một số nãy gì đọc cho em cái tại vì lúc đó nó còn nhỏ gì dắt nó đi chị dùng số chị rất lâu lắm là
Đi xem.
kịp rồi nha. Té nha, té xíu. Lấy nhẹ. Tại vì có cái đây cái da nó mỏng á. Cái này đau hơn vùng trên. Nhưng mình phải chịu khó mình lấy, không lấy nó viêm. Nhưng sau mình lấy là nó còn đau hơn nữa đó. Bình thường nhà em có thoa thuốc gì không?
Không.
Chỉ rửa mặt thôi hả? Rửa mặt có rửa dưới vùng này không?
Có.
Chịu khó rửa cho nó sạch nha. Có chơi thể thao không?
Có.
Chơi thể thao xong rồi chịu khó nhớ rửa mặt là liền nha. Để thôi mồ hôi á. Tất cả.
Clearer skin. Heat and humidity increase sebum production and promote bacterial growth, worsening acne. People living in tropical climates or hot, humid environments experience more significant acne than those in cool, dry climates. While you can't change your climate, understanding that heat worsens acne helps you implement compensatory strategies. Increase air conditioning use if possible. Use a humidifier in dry climates to prevent the skin barrier compromise that can paradoxically worsen acne. Keep skin cleaner during hot, humid times when sebum production is highest. Sweating creates moisture that promotes bacterial growth in pores. Athletes or people with active occupations experience acne worsening related to sweat. The solution is simple: shower immediately after sweating, change into clean clothes, and avoid touching your face during exercise. Exercise itself is beneficial for stress reduction and hormonal balance, so don't avoid it, just manage post-exercise hygiene properly. Friction from tight clothing, athletic equipment, or repetitive face touching, occupational hand-face contact, can trigger acne. Friction acne appears where contact occurs, under helmet straps, where backpack straps compress skin, on the jawline from phone contact. Wearing loose, breathable clothing, ensuring equipment is clean, and avoiding touching your face helps prevent friction acne. Occupational chemical exposure contributes to acne in certain professions. Workers in automotive, petrochemical, or metalworking industries' exposure to mineral oils, cutting fluids, and other chemicals experience acne, occupational acne. Wearing appropriate protective equipment, washing thoroughly after work, and changing out of contaminated clothing help prevent this exposure-related acne. Chlorine exposure worsens acne, particularly in swimmers. Chlorine is drying and irritating to acne-prone skin. Swimmers should rinse immediately after swimming to remove chlorine, wash hair to prevent chlorine transfer to facial skin, and use protective products before swimming if possible. Air pollution contains particulates and oxidative stressors that settle on skin, potentially worsening acne. People living in high-pollution areas experience more acne than those in low-pollution areas. While moving isn't feasible for most people, understanding pollution as a contributing factor helps. Using air purifiers indoors, minimizing outdoor time during high-pollution days, and thorough daily cleansing to remove particulates helps mitigate pollution effects. Secondhand smoke exposure contains numerous irritants and oxidative stressors. While not as significant as direct smoking, secondhand smoke exposure is associated with worse acne. Avoiding secondhand smoke exposure is beneficial. Stress from work, relationships, or other sources increases cortisol, promoting inflammation and acne. High-stress occupations correlate with worse acne. Implementing stress management is therefore essential. Exercise, meditation, adequate sleep, and time away from work all reduce work-related stress and its acne effects. Blue light from screens, phones, computers, tablets, may contribute to acne through unknown mechanisms, though evidence is still emerging. Some evidence suggests blue light increases inflammatory markers. Limiting screen time, using blue light filters on devices, and taking frequent breaks from screens might help, particularly for those with screen-heavy occupations. Hard water, high mineral content, may contribute to acne through various mechanisms. Installing a water softener or using a shower filter might help if you have very hard water, though evidence is limited. At minimum, thorough rinsing after cleansing ensures no mineral buildup remains. Tap water quality varies by location. Some tap water contains significant levels of chlorine or other chemicals potentially irritating to acne-prone skin. Using filtered water for rinsing after cleansing or using distilled water as a final rinse might help those with particularly sensitive skin. Hormonal disruption from endocrine-disrupting chemicals in products and the environment contributes to acne. Bisphenol A, BPA, and phthalates in some plastics can disrupt hormones. Using BPA-free bottles and containers, reducing plastic use, and choosing natural products when possible reduces exposure to potential endocrine disruptors. Occupational stress combined with other factors creates a synergistic acne worsening effect. Someone working a stressful job in a hot, humid environment while wearing work clothing that causes friction experiences multiple acne-promoting factors simultaneously. Addressing modifiable factors helps mitigate cumulative effects. Understanding your specific environmental and occupational exposures allows you to make targeted changes. If heat and humidity worsen your acne, cooling strategies help. If your occupation involves chemical exposure, protective equipment helps. If stress is primary, stress management helps. Identifying your specific environmental contributors guides your approach to minimizing their acne impact. Guide 33: Advanced Retinoid Protocols and Optimization Strategies. Retinoids represent some of the most powerful acne and anti-aging treatments available, but optimizing their use requires understanding advanced protocols and strategies beyond basic application. Mastering retinoid use transforms results. Retinoid strength exists on a spectrum from gentlest, over-the-counter retinol, to most potent, prescription tretinoin. Over-the-counter retinol at 0.25 to 0.3% concentration is appropriate for first-time retinoid users. After establishing tolerance over 8 to 12 weeks, you might advance to stronger formulations. Retinol, retinaldehyde, at 0.05 to 0.1% concentration offers intermediate strength between retinol and tretinoin. Prescription retinoids include tretinoin, Retin-A, at 0.025 to 0.1%, adapalene, Differin, at 0.1%, and tazarotene at 0.025 to 0.1%. The difference between 0.025% and 0.1% tretinoin is substantial in terms of strength and irritation potential. The start low, go slow principle maximizes retinoid tolerance. Begin with the lowest concentration at the lowest frequency, 2 to 3 times weekly. Resist the temptation to speed up progression. After 4 weeks at your current concentration and frequency, assess tolerance. If you're experiencing minimal irritation and want faster improvement, increase frequency to 3 to 4 times weekly. After another 4 weeks, increase to 5 to 6 times weekly. After another 4 weeks, use nightly. Only after reaching nightly use at current concentration should you consider increasing concentration. This progression takes 12+ weeks but maximizes adaptation and minimizes retinization phase severity. The retinization phase, temporary redness, dryness, peeling, and potential acne worsening, is unavoidable but manageable. Rather than viewing retinization as treatment failure, recognize it as adaptation